Today we have our moderator, Professor Wang from the Department of Radiation College, Tang University Shanghai Cancer Center. He's an associate professor at the department, and he specialized in the field of medical physics and adaptive radiotherapy, with research interests focusing on AI-driven radiation treatment planning, radiomics, and translational medical physics. Dr. Wang has led and participated in multiple national and regional research grants, contributing to the development and the clinical implementation of advanced radiotherapy technologies. His recent work centers on generative models for personalized tumor radiation and the integration of AI in radiation systems. So I will hand my microphone to Dr. Wang. So please, Jiazhou Wang.
Yeah, thank you for the Professor Jin. Yeah, it's a long introduction. Good morning, good afternoon, this afternoon, each bring us his insights in this clinical, technical, and research aspect of the MR-guided radiotherapy. Our program and after those sessions, we will have a Q&A discussion. If you have any questions, you can input in the chat part. So we can start that Q&A session at 4. Sorry, I was offline last. So I will just introduce Dr. Jiayun Chen. She was a principal investigator for one of the national Nature Science Fundamental China NSFC project, and she was very good at the treatment planning. So she talks about his topic. Dr. Chen. Yeah, you can continue.
Hi. Hello? Hello?
Yes, I can hear. My network seems not good, so you can start your talk.
So can everyone hear me? So may I share my PowerPoint and begin my presentation? Okay, can everyone see my slides?
Yes.
Okay, that's great. Okay. My talk will be okay, let's begin of my talk. Ladies and gentlemen, good afternoon, distinguished guests and fellow researchers. I'm Jiayun Chen, working as medical physicist in Cancer Hospital, Chinese Academy of Medical Science. It's my distinct honor to be here to present the talk about the artificial intelligence drive the real-time tracking of tumor targeting motion in MR-guided radiotherapy. My talk will be in 5 parts. The first part is the challenge of real-time motion tracking, and then in second and third part, I will present an introduction of MR-guided and AI algorithm for motion tracking. The first part is our work about the tumor tracking, and finally is the summary of our automatic real-time motion tracking method. Let's do the first part, challenges in real-time motion tracking. As we can see that the position, the size of the target and organs can change during actual course of the radiotherapy, leading to potential of target or toxicity. The interfractional displacement include the patient setup errors, tumor regressions, and anatomically verifications, such as blood volume, intensity location, and weight change, which can correct using online or offline adaptive by modifying the using plan based on the up-to-date image acquisition before a fraction. And the intrafracture motion changes may be caused by the patient or organ movement, such as breathing, heart beating, and for this picture, you can see clear that this one is gas intensity peristalsis, which can be corrected by respiratory gating technique, body image, and real-time tumor tracking radiotherapy. Image guidance radiotherapy is based of the inter and inter-fraction texture change management applied as a pre-fractional image guidance reduction, even real-time IGRT. AI-based models have been introduced to manage this motion and software error. Traditionally approach to motion management in radiotherapy, such as respiratory gating and using federal markers, and limited by their accuracy and the invasive nature of the procedure. Current techniques frequently necessitating investor steps and don't offer the high resolution of soft tissue image that MR provides, which is crucial for precise treatment planning and execution. Let's come to the part 2, introduction for the MR-guided radiotherapy. As we all know that it's a physical challenge to integrate MR integral MR and MR linac. MR scanner and linac is a highly sensitive piece for medical equipment with the mirror electromagnetic interfaces. In the world of BG flow, there are two machines allergic to each other. The successful integration of a regional incompatible MR system into a linac system is a significant technical achievement. MR-guided radiotherapy for liver cancer, for example, enhanced by MR-based linac, offer clear soft tissue imaging, enabling adaptive and gated therapy, translating the personalized treatment through routine functional image. The enhanced efficiency achieved through by real-time image, which facilitates adaptive adjustment to the treatment plan. This dynamic approach not only boosts the effectiveness of the therapy, also minimizes the unintended side effects to health issues. Additionally, we should note that MR-guided radiotherapy enhance geometry precise by mitigating setup error that's guaranteed that in the radiation dose is delivered with the highly accurate to the technical area. Furthermore, MR-guided radiotherapy enhance the personalized treatment strategies that are tailored to each patient a unique anatomic and tumor profile, optimizing treatment outcome. One of the primary challenges of the motion tracking with the MR-guided radiotherapy is the identification of the complex motion patterns due to the integrative movements that tumor and the organs may undergo during the treatment procedure. Traditional tracking methods may not accurately capture this motion, leading to the decrease of the treatment precision. This necessitates the assistance of AI to enhance the accuracy of the tracking. So let's come to the AI algorithm for motion tracking. With the development of MR rapid past a few years, the explosive growth in medical big data, AI promised to revitalize the field of radiotherapy through the highly automatic workflow, enhance the quality assurance, improve the regional balance of the expert experiment, and individualize the treatment guided by multiple arms. The figures summarize the data generated during the radiotherapy workflow that used to train AI model for different purposes. The applications span across key work study, including diagnosis, evaluation, simulation, contouring, planning, QA, treatment, and post-radiotherapy. The upper figures show the modern AI, including classic machine learning and deep learning, has been successfully applied to analyzing image data and pre-motion radiotherapy. From the upper figure illustrated the dramatic increase in the number of the publication rated classical machine learning and deep learning based motion management since 2010. And notably, the optical deep learning has surged exponentially since 2017, reflecting growth significantly in this field. Meanwhile, in the down figures, we can notice that the static analysis for AI-based target tracking in PubMed since 2005. It shows that among classic machine learning algorithms, neural network, spot vector machine, and boost algorithm are the most widely used for tumor tracking. NN stand out due to their ability to capture the both dynamic and structural phenomena, as well as their efficiency in noise suppression, age detection, and image enhancement. The workflow of real-time motion management in MR-guided radiotherapy involves several key steps. Initially, a 2D thin MRI is applied to visualize the patterns, patient moving anatomy. Subsequently, the position of the moving target is localized on the current thin MRI. To address the system latency, the future target position can be predicted. Finally, the radiation beams is adapted to compensate for target motion using one or two combined of various techniques. Target location algorithm may be solely on current image, but more commonly, they leverage prior knowledge such as target shape from the planning image. Here is the deep learning for faster deformation registration from Hans team. Hans team therefore and evaluate a deep learning model for the faster deformation image registration using thin MRI data acquired during the radiotherapy, and compile this one potentially for real-time target tracking and the conventional image registration method. Patient setup and thin MRI acquisition illustrated in Figure A. Continuous thin MRI was captured at the rate of 8 frames per second throughout treatment section that typically lasts 15 to 20 minutes. Figure B outlines the frame analysis with treatment liver video, including the tracking confidence levels, spin on off time, and frame to frame root mean square errors. Subsample of thin frame. The procedure of subsample involves extracting special thin frame between the deep inspiration breath hold and free breath phase, identified through peak detection on time series data. Deformable registration example in Figure C demonstrate an example of deformation registration using very thin MR frame during the inspiration phase. And the registration arrow components in Figure D shows a box plots that compare registration arrow in different methods, such as affine, baseline, and demo. Highlights the performance of the deep learning shows in the pink based on the registration have a good result. We can note that the study involved the analysis the extent of thin MRI, especially over 21 hours worth, more than 629,000 frames, gathering from 21 patients across the 18-6 treatment section. Here's the first two examples. The first patient exhibit high tracking confidence throughout the video, expected during the frame affected by guiding artifact. The second patient shows the subsequently variation in tracking coefficients at both beam on and beam off times, indicating more difficult to maintain consistently the tracking. Here's a summary of this work. The performance of the matrix value focus on two metrics. One is registration error. The deep learning regression demonstrated super performance with the root mean square error value of 0.032 compared to a fine, baseline, and demo. And the computation times deep learning registration is pretty faster. Complete each frame in 8 microseconds. Outperformance to the offline, baseline, and the demos method. The special stability among the deformation registration method and the spine stability of the motion vector was found to be comparable across the model method. The temporal consistence, the deep learning model notably improved the temporal consistency of the MVF, indicating more reliable tracking over time. The above one is the 2D CMRI tracking. How about real-time 3D MRI image? That's faced more challenge because the 2D MRI, the real-time 3D MRI it's more challenging because the real-time 3D magnetic image challenge of the slow MR signal acquisition, leading to high undersampling case spacing depth. By Southstein proposed a deep learning-based case spacing drive the deformation registration network named the KS-RegNet for real-time 3D MR image by incorporating prior information. KS-RegNet performs a deformation image registration between a fully sampled prior image and onboard image acquisition from highly undersampled case spacing data. To generate a high quality onboard image for real-time monitoring, figure 1, this one is illustrated flow work of the proposed KS-RegNet. The network consists of several key components. An input data generated block that prepares the full sampled source image and unsampled target image for registration. A unit column block that predicts the deformation vector to align the source and target image. The diffeomorphic integral layer ensures that the DVF is smooth and inventable, and the spatial transform layer that apply to DVF to deform the source image to match the target. The registration accuracy is evaluated in case spacing uses the fidelity loss to avoid the impact of unsampling artifacts, and smoothness loss is added to recognize the DVF. The Radiotherapy is a basic version that directly compared to the registration ensemble data in the image domain, which can be sensitive to artifacts. Plus the KS-RegNet involves up-RegNet by incorporating an additional unsampled source image as imports, allows the network to learn and mitigates the unsampled artifacts more effectively. The paper proposed the KS-RegNet further enhance this approach by evaluating the registration accuracy directly in case spacing rather than the imaging domain, making it more robust to unsampling artifacts and provide better overall performance for real-time MR motion estimation. Let's have a look at the result. The figure A and B provide a relatively comparison of different deep learning registration models, RegNet, KS-RegNet, KS-RegNet, under abdominal dataset. This one shows registration result. In 3 view, we can clearly see that KS-RegNet achieved the best alignment with the target image, especially near the liver boundary. Under the figure B, further support this by comparable the line profile, which one shows in the red one. Where CAT-net demonstrate the superimetry accuracy. This figure collectively illustrate the case recognized approach is incorporating additional understanding and sampling source image and evaluating registration in case spacing significantly enhance registration procedure. Outperformance are the method inherently under sampling artifact. And the article conclude that the proposed case recognized framework effectively addressed the challenge for real-time MR motion estimation using highly unsampled case spacing data. Case recognized demonstrate superior performance compared to conventional methods like elastic and other deep learning architectures, achieves accurate and robust registration results across very unsampling factors. The network unsupervised training approach eliminates the need for ground truth deformation vector field, make it more practicable for real-world application. Additionally, case recognized shows stability and consequently in registration accuracy, even when unsampling pattern vary between the training and the testing. The framework ability to generate a high quality unbodied image with seconds latency make it promise here for real-time MR-guided soft tissue tracking, tumor localization, and adaptive radiotherapy planning. Further work about the focus on enroll more patient exposure different MR acquisition protocol and need to validation in this framework to accuracy and robustness. Let's come to our research. Our research include also do the motion tracking in 4 critical paths. First is the image pre-registration to enhance the image quality. We use a long reference image quality assessment to clinical applicability. We enhance the tracking learning detective framework, including 2 parts. One is an advanced medium workflow tracker to sub-millimeter precision, and the other improved detector is the dynamic research region adjustment. We also introduced the improved Chen's worst model to accurately track the declination. This study is encompassed to 122,800 frames from 10 patients. The origin TLD is a machine learning algorithm for long-term packet tracking in video skins, was significantly enhanced to adapt to MR packet tracking scenario, as illustrated in the left figure. Notable enhance was circled in red. We reduced the sliding window scale factor and adjust parameter levels and increasing labeling size of the LK algorithm. We also increase the algorithm iterations for enhanced procedure. Finally, integrate enhanced TLD with the Chen model for automatic segmentation. The method performance was used mean absolute error as a primary metric for tracking accuracy, completable by the correlated coefficiency. The precision and recall rates calculated for each patient data for segmentation. The death coefficient was employed for common metrics, as shown in the equation. The real-time capability was measured in frame per second. Let's come to the result. Let's illustrate the typical tracking outcome for our enhanced TLD across very treatment fraction for patient 1. The blue line signifies the ground truth, while the red line represents our method prediction. We can notice that there's a minimal divergence. The right side image displays the typical frame that's except for tracking, as indicated by the yellow breaks the circle fitting the vessel. The figures juxtapose the tracking performance of our proposed method, improved the TLD, and against the original all TLD across all the data sets. The include TLD, maintain tracking error within 1 millimeter, which shows in the purple. And the green one is OTLD, with precision rates is consistently above 99% and the useful rates over the 98%. In contrast, OTLB shows in the green line exhibit markedly lower precision and recall. How about the targeted segmentation? The typical segmentation result for one patient was shown on the right, with the red and the blue outlines representing the ground truth and the prediction, respectively. The calculation marks the close line with the ground truth, with a global dice variation exceeding 18.2 for all patients and average 7%, underscoring our method robust segmentation capability. Our method pursue average tracking of FPS of about 22 and average segmentation FPS about 25, with a total processing time under 100 microseconds. While recommendation by the AFOMP, the real-time efficiency should be less than 500 microseconds. We are far more less than this. In summary, our study successfully developed and validation automatic real-time motion tracking for MR radiotherapy, significantly surpassed the existing method by tracking accuracy less than 0.8 millimeter and precision and recall rates exceeded 99% and 98% respectively. A global death coefficient above 82%. How about the future direction research opportunity? We should notice that quality assurance of AI model in radiotherapy is crucial to ensure patient safety, regulatory compliance, and clinical relevance. QA process help verify the accuracy and reliability of AI model, and identify and correct errors and ensure the consistent performance across different scenarios. By building trust among clinicians and regulatory bodies, QA facilitates the widespread adoption of AI in the clinical scenario and practice, ultimately enhance treatment outcome and patient care. The figure on the right outlines the workflow for this commissioning, implementation, and quality assurance for new AI model in clinic. It illustrated that the commissioning began during the development phase of the AI model. Once the model is built and this model is adopted, commission enters the second phase, which involves testing the model with an independent data set to evaluate its performance and robustness. For major updates to the model, the procedure should return to the first part, which minor updates only require repeating the second pass. This structured approach ensures that the AI model is throughout the validation and integrated safety to clinical practice. About the clinical application of AI models, particularly those based on deep learning model, is currently limited due to several facts. First, many models don't provide confidence scores for their prediction, making it difficult to assess the one human expert inventions is required. Secondly, the interpretability of these models is low, which is a significant barrier for clinical use when while the understanding the decision-making process of the model is crucial. Additionally, there is a lack of a standardized method to effectively evaluate and compare different models that perform the same function, which one the ability to ensure the best models are selected for the clinical use. This limitation underscores the need for further development of AI models that not only accurate but also transparent and easy integratable into the clinical workflow. Here come to the summary. We discussed the challenge in real-time motion tracking, including interfractional motion, introfraction motion, and we introduced the MR-guided radiotherapy with the AI algorithm. We take two examples about deep learning for 2D thin MRI factor deformation registration and for real-time 3D MR image. We also discussed our improved TLD with automatic translation for real-time motion tracking. Finally, we discussed limitation for clinical application for AI. Okay, that's my end of my talk.
So thank you, Dr. Chen. Thank you for your nice talk and excellent work. So we will have a next speaker. Our next speaker is Dr. Tang Yuan. Dr. Yuan Tang. Dr. Yuan Tang is an associate professor, associate physician with PhD, is a radio oncologist, work at the Cancer Hospital or Chinese Academy of Medical Science Department of Radiotherapy. He is focused on the research active in radiomics and artificial intelligence, aiming to personalize the treatment plans through the combination of radiotherapy and immunotherapy. He was dedicated significant phase 2 and phase 3 clinical trials on the gastric cancers. So today his talk is the benefits and the challenge of rectal cancer MRI-guided radiotherapy from the perspective of a physician. So Dr. Chen, Dr. Yuan. So yeah, I will hand to the
Thank you. Thank you, Professor Wang. Can you hear me?
Yes.
Yes.
Okay. Good day, everyone. Thank you, the professor. Thank you, the president, and thank you, the moderator, Jiazhou Wang. It's my honor. It's my honor here to enjoy my experience in the Unity in clinical practice. Today, I will explore rectal cancer, MRI-guided radiotherapy, benefits and challenges. I am a doctor. I'm a registered. I'm Dr. Yuan Tang at the Cancer Hospital from the Chinese Academy of Medical Science. Also the same way to the Dr. Jiayun Chen. Today we will cover MR's critical roles in staging, precision radiotherapy technique, MRI-guided technology, clinical outcomes, and the future challenges. Section 1, the role of MRI and the radiotherapy in rectal cancer. Locally advanced rectal cancer, not for all the staging. Local advanced rectal cancer demands precise staging. MRI is now the international golden standard for evaluating local advanced rectal cancer, surpassing CT scan in visualizing tumors and critical anatomy. Some key studies have confirmed MRI's superiority. For example, superior GTV or the superior tumor and the organ at risk visualization. Also, the MRI can reduce the segmentary volume with a CT because it will minimizing irradiation of normal tissue. So MRI is the golden standard for investigating and assessing local advanced rectal cancer. The following parameters should be determined in baseline MRI in clinical in clinical situation. We can see from this image, we can see the tumor location very clearly in this T2 weighted image by MR. So this is very important for us to, it will tell us how to do the resection. Also, the MR could also show us the substation of T3. Substation of T3 means the depth of invasion beyond the mucilaris propria. Because the substation of T3 is very have many more meaningful. For example, T3A and T3B means some good prognosis, but T3C to T3D means more recurrence in the patient. Also, the MRI will show us a clear MRF signal, mesorectal fossa involvement. If the tumor is MRF positive, it means the tumor cannot be resectable. It will be very near. Also, the MRI will show us the EMVI, extramural vascular invasion. For example, EMVI positive tumor, score 3 to 4, also always indicates higher recurrence risk. Now, let's come to the precision radiotherapy techniques for rectal cancer. Precision radiotherapy leverage IMRT, VMAT, and tomotherapy to target large pelvic volumes while sparing OARs. Key details include radiotherapy is also effective and the therapeutic effect for rectal cancer. In clinical, long course concurrent chemoradiotherapy or short course radiotherapy, also used 5 grades plus 5, is also allowed in clinical. And the pelvic radiotherapy is also large target volume. We can see the image is very large, not like the SBRT for the little tumor. The target volume also includes the lymph pack drainage area. So this is the rectal cancer's radiotherapy. We will have 3 pillars of precision in rectal cancer strategy. Macroscopic precision radiotherapy is also including accurately guessing the indication. We should choose the patients to receive the radiotherapy. He may benefit from this treatments. Also include the precision chemotherapy sensitization program. Also including precision chemo targets immunotherapy combined strategy. Second, precision radiotherapy should also based on the position and the radiation dose and the biology effects. As we know, accurate location also means low toxicity. If we treat with them more accurately, we have lower toxicity. Then precision dosage made us can increase radiotherapy dose, so we can get more perceived organ function. Then biological effects, we should use the suitable segmentation mode. You should, for example, for one person, you choose 15 green in in 25 fractions or 5 gray plus 5. I should think more situation. The third, the preservation in position. Because if you can use the radiotherapy model to predicting the radiotherapy sensitivities and the prognosis, you have the more accurate therapy for the patient. Okay, in the rectal cancer treatment, non-operative management is revolutionary for patients. Achieve clinical complete responses. It's based on the following reasons. Surgery has a definite impact on quality of life. If the patient could omit the surgery, he will or she will have good quality of life. Second, endoscope combined with imaging to evaluate the tumor response after neoadjuvant treatments could be associated with the PCR. So we can use the image, for example, use the MR image compared with the endoscopy to evaluate the response. If the tumor dispute, we think maybe this disease is either CR. Maybe it's very high relationship with the PCR. The third, similar to the anal squamous cell carcinoma, surgical resection is not in the first stage. It's only a remedial measure if it does not affect the survival rate. So the precision radiotherapy for rectal cancer, in most situations, we can use the precision radiotherapy to increase radiation dose. In this slide, we can see if we use the external irradiation, conventional doses of 55 to 50 gray will result in the PCR rate of 15%. If we increase the dose, another high dose of about 55 to 60 gray will result in the PCR rates of about 24.1%. But it's not high. It's not high. Surprising. Danish WW2 study showed us very surprising results. 62 gray external beam can result in 6% CCR rates and 73.8% of 2 years local control. It's a very good result. We also can use intracavitary or contacts in radiation therapy to increase the radiation dose. We can see the OPRA study. Chemoradiotherapy plus the contact radiotherapy about 90 gray in 3 fraction using the contact radiation result in a 3 years organ function preservation rates about surprising 81%. So precision radiotherapy has great potential in organ preservation for rectal cancer. For the patients who achieved clinical completely response after external beam radiation therapy or intracavitary radiotherapy or contact radiotherapy, a non-surgical strategy of observation and waiting may be a appropriate treatment option. And as many studies reported, anal rectal function toxicity after position radiotherapy is tolerated. So it's a future direction. Section 2, overview of MR-IGRT technology. MR can clearly display as we know, can clearly displays anatomic structures differentiated tumors from the normal tissues and the precise target boundaries for CT indistinct lesions. We can see that in image. For example, this is an example. A male patient with 50 years old, mid rectal cancer stage T3B and 2 M0 with MIF positive EMI about score 3. We can see the image from the unit. We can also see the tumor in here, transverse in corner or in sector, comparable to the 3T MRI. Also for the functional image, we can also see the tumors in the MR image from Unity compared to 3T MR. The Unity integrating MRI into clinical accelerator can improve envisionation of treatment volume. So we can see directly the treatment area. So Unity also can make the online adaptive radiotherapy and can daily anatomic changes we can see and enhance the treatment outcomes. So MRI guided online adaptive radiotherapy. If a doctor use this machine, you can reduce the treatment margins. So as we can reduce the toxicity risk and increasing the likelihood of CR rates for rectal cancer, then more patients will achieve the CR to omitting the surgery. So for the rectal cancer, this tumor is a promising indication for MRI guided radiotherapy. This is the example. This is a radio. We can see in this radiotherapy, we can see this tumor invisible on CBCT, but can be seen in the MR. So we can monitor anatomic changes and the progressive tumor shrink during the treatment. So it will make us enabling adaptive dose escalation. Section 3, treatment margin reduction. As we know, CBCT-based treatments have some limits. For the rectal cancer, large margins to convert CTV to PDV due to daily variations in rectal and the bladder filling. So the treatment margin requires to cover 90% of the interfraction CTV motion. With conventional non-adaptive radiotherapy technologies may reach 2 centimeters. It's very large range for lesions located in the middle and upper rectum. So it will increase the risk of toxicity and limit the prescription dose and reduce the chance to achieve CR to omitting the surgery. But in the Unity, we see the difference. It is an example. The study include 15 patients with rectal cancer. The patients will receive radiotherapy fraction 5 grain plus 5 fractions using 1.5 T MR clinic. Each patient underwent 26 MR scans. The 3D expansion of the GTV reached 95% motional coverage, and the expansion distance covering the GTV motion within and between fractions were evaluated. We can see there was 3 analyses. A representing interfraction motion analysis, B representing the intrafraction motion analysis, and C is time interval analysis. From this figure, we can see the changes in the GTV position with the infractions. We can see the GTV will moves a little, but it will be moving. And we can, from the 0 minute, 30 minute, 20 minute, and 25 minute, there are some changes in GTV position. We can see these changes clearly in the MRI image. So this study also showed that for the interfraction or intrafraction, the GTV extension distance requires to cover 95% of GTV motion. Between and the within fraction were 17 millimeter and 6 millimeter respectively. So it can be included in my clinical practice. Also, the time interval is very important. You can see this figure. There were many curves about different time intervals, 0 to 5 minutes, 5 to 10 minutes, and 10 to 50 minutes. You can see the 3 curves. Okay. Online MRI guided radiotherapy locally dosed increased. The shorter treatment time, the smaller GTV movements. When the treatment time is shortened to about 15 minutes, we can see the 3 curves. 4 millimeters can meet the coverage requirements is enough. There are some other studies have the similar results. This study tells us using MR-Link, the MR image can produce position images with superior soft tissue contract. It allows significantly reduce the safety margins compared with CCT, and will providing additional advantage of avoiding additional radiation exposure. There are some other studies results similar results. This paper published in the Radiation Oncology tells us reduce the margin to 4 millimeters in the lateral and the posterior directions, and the 6 millimeter in the other directions is enough. They will retain coverage of the mesorectum in all the studied cases, except when the gas passage, because the gas passage will lead to mesorectum dilatations. And this study also tells us use only 3 millimeters GTV to PDV margins will enough. It will ensure 95% GTV dose coverage in all their test cases. This study published in Clinical Translation Radiation Oncology, including 22 patients with local advanced rectal treated with the Unity. We can say use only 5 millimeters actual pocket margin of 5 millimeters. It is enough for the GTV and the corresponding mesorectum. And the use 7 millimeters is enough for elective pelvic lymph nodes. So this tables tell us if we use the Unity, we can reduce the margin and reduce the toxicity, and maybe we could make more patients to achieve the CCR. Section 4. Unity treatment process. In our center, there were traditional Unity treatment process. In the prepare staging, we make a CT simulation, MRI simulation, and we control the target and the OARS, and we made the domestic planning and plan verification, so we can get a reference treatment planning. When use the Unity, we should make the patient step MRI verification. Importantly, we can use the ATP or ATS technology to achieve online adaptive treatments, adaptive plan formulation, and be verificated, so we can go to the treatment delivery. And during the treatment delivery, we should use MRI real-time monitoring to see the range. But in our comrades Jiayun Chen, we also can use the AI procession. Maybe it's in future. Sorry. So this is an example. This is an example. Unity treatment process. We can see this picture as it's plotted as the pinnacle denotation of the targets and the OAR. We use the pinnacle. Then we use the molecular plan design. Then we go to the online plan and treatment delivery by motion monitoring. The online plan is very meaningful and complicated. We can use the ATP or ATS to optimize this plan. ATP position-based registration. For rectal cancer pre-treatment positioning, imagine the online MRI the registration results. Optimize the change of target position. Not change the targets on OAR. Used in case of small registration error. Small change of the targets in the OAR. Also for the rectal cancer, when we treat patients with pelvic area is a large target, we usually use ATP, but we boost the dose to the tumor. We use the ATS. ATS is the shape-based registration. After the reference plan, imagine is registered with the online MR demonstration, and the target area and the OAR are optimized. That is usually used when the area is large and the tumor or OAR control changes greatly. We can see the patients in different fractions. We can see the changes very large between the fractions. Okay, this is the example for the online plan, adaptive plan by fusing the pre-treatment MR image and the CT. We can see from the MRI image can clearly show the tumor and the MRF and the EMAI condition, which is helpful for diagnosis of the tumor. Just like we see the MRI image from the diagnosis MRI. So we can compare the reference plan with the online plan. The online plan and the reference plan were basically equivalence in terms of targets, conformality, and the dose distribution and the OAR doses. The doses difference and the conformality difference are affected by the patient's bladder fairness, rectum fairness, and the positioning on next day and online planning differences. So this is an example. We can see daily online plan. We can see the tumor and the area. We can see this to ensure target coverage and reduce the dose to the open end risk. And then we can see the doses to PTV, bladder, colon, intestine in this table. So we can make the treatment very safe. Another author published the papers. It has many others process. For example, this paper tells us we can administer 100 millimeters ultrasound gel. Oh, for the booster stage, we can see If we use the ultrasound gel, we can see the tumors very clearly. So it will be very accurately to boost the doses to the tumor. Boost 1, 2, 3 is very accurate. Section 5, online adaptive MRI guided radiotherapy in local rectal cancer. So as to the plan, MRI unity plan, this paper showed us comparison of the quality of clinical plans and MRI clinical plans. And this paper, including 8 patients with rectal cancer. In this paper, comparing the parameter settings for the 3 plan. The 3 plan ensures PTV coverage and minimize OAR doses, optimizing the plan and the goal. The victim care plan was readjusted, meeting all clinical aseptic criteria. So we can say, compared with the clinical plan, the MR clinical plan for the rectal cancer resulted in an increase in dose mean bladder and the bowel area median dose mean of 2.9 green and the 4 grains respectively. But the PTV dose mean and the D1 present and OAR dose of the PINSA MRI clinical plan are comparable to those of MRI clinical. So the conclusion of this patient is that given the feasibility of a high-quality MRI clinical program in clinical, we support the clinical introduction of the MRI clinic. For example, in a patient, we can see compare the reference CT plan and the MRI plan before treatments. We can see it's very comparable. And the dose attribution during treatments, we can also see that this very clear. Rectal lesion shows larger interfraction motion, mostly caused by daily volume changes in surrounding pelvic organ, bladder, bowel, loops, rectum, and the displacements compensated subsequently using the MR guided therapy. Section 6, fictional imaging and personalized treatments. If we can use the predict model, we can treat patients more accurately. This study, the research objective is to establish a 2 years disease-free survival prediction model. GTV was delighted on MR image of MR guided radiotherapy and 1,067 radiomics features were extracted using the multi-DICOM platform. This performance of predicting 2 years DFS was studied by main. In all, 48 patients with lower rectal cancer were included, and these patients received chemoradiotherapy in 2 centers. The radiomics features, including morphological and statistical and textual factors. The results, a total of 1,099 variables were collected and evaluated in 2 different models: the radiomics and the clinical. So they found the best performance in 2 years DFS prediction model was the delta radiomics models based on the change in area or surface ratio between 54 gram BD and the simulation. So this is one of many similar studies using the radiomics topics to analysis. Section 6, ongoing trials and challenges. Not many. We can see the doctors focus on the evaluating different strategy in terms of both the timing and the strategy. The purpose was to assess the efficacy and the toxicity of online adaptive dose-escalated radiotherapy. Patients choose challenge. It's also should in the conclusion. As to MRI incompatibility, metal implants, pacemakers should be noticed, and the clinical maladaptation. Patients may be clinical unsuitable for MRI scans due to claustrophobia, severe anxiety, pain, or inability to one patient for extended period. As to the patients, maintain a fixed position is a challenge. Maintaining a fixed position on the treatment table for extended periods is necessary to ensure precise treatments. In closing, MRI-guided radiotherapy revolutionized rectal cancer care. Precising targeting, organ preservation, and adaptive dosing challenges remains, but ongoing trial promise refined protocols. That's the end of my presentation. Thank you for your attention.
Thank you. Thank you for the Dr. Tang. You almost covered every aspect of the MRI-guided radiotherapy in rectal cancer in clinical. So we will introduce the third speaker is Mr. Chen Shirui. Mr. Chen is also come from the Chinese Academic Medical Science Cancer Center. He is familiar with the operation specification on various linear electron accelerator radiotherapy, respiratory motion management, and clinical application on MRI linear. A member of the clinical guide committee of the MRI linear alliance. So, Dr. Chen, can you speak? Yeah, give us.
Okay.
Thank
you, moderator. Thank you for the introduction. Can you see the screen?
Yes.
Okay. Okay. Hello, everyone. I'm Chen Shirui from Chinese Academy of Medical Science. Today, I'm going to talk about some technologies about MR-guided radiotherapy in treatment delivery from the view of RTT. I will present my content from the following 5 aspects. First, I will introduce Unity simply. Second, I will talk about the clinical workflow. The third is the challenges in ART, what we face now. Then, for the challenges, we need to make some rules expansion. At last is the perspective for the MR-guided radiotherapy. Okay, this is the picture of our Elekta Unity. This is taken from my telephone. As we know, there are several products of MR-guided radiotherapy, such as MRDN of Shirui. However, Elekta Unity is the only one entered the Chinese market, and it is the first high-field magnetic resonance combined with LINAC. So, what about today's technologies in this topic are based on Unity? It mainly have 3 parts. The first is 7 MV flat frame free accelerator. It has a slim ring gantry on the outcycle with 80 pairs of agility MRCs. With the isocentric projection wise was about 7 millimeters. The second part is a 1.5T magnetic resonance image system on the inner cycle, which can provide verified images and multi-purpose imaging, which contains planning, motion management, function imaging. The third part is the online planning system. It's Monaco. This is the journey of our Center of Unity. On May 3, 2018, new clinic room began to construct. On May 23, 2019, acceptance started. In November in the same year, commissioning was completed and the first patient was treated. This picture shows the last fraction of our first patient on Unity in our center. In last month, the clinical process training for Unity at our center, Langfang campus, was completed. That means another Unity could be used in clinical in our center in Langfang campus. This picture shows the patients admitted on Unity from November 2019 to the last month in our center. We observed that the gap from the December 19 to October the 20 is the time for the permission of the Unity to for entering China, because CMS was the first hospital in China which conduct a clinical trial for Unity. Then the numbers are increasing slowly but steady. And from June 23, the numbers were stability at about 30 per month. Till now, we have treated more than 800 patients on it. And this picture shows that the distribution of diseases in our center. I divide them according to the treatment site. From this image, it can be observed that the region with the largest proportion is brain tumors, the vast majority of which are metastatic tumors. Then there are liver tumors, which include local liver cancer and another liver metastatic tumors. The third largest is prostate cancer. Then the breast cancer. Next in the sequence is spinal tumors. The vast majority was mets. Then rectum cancer, lung cancer, and tumors in head and neck areas. And from this picture, we can see another point is that almost all the kinds of tumors were treated in Unity. That indicates that almost all kinds of cancers could be treated on it, even in some anatomical sites that are conventionally considered not suitable for MRI examination, such as lung cancer, which even arrived at 5.4% of the whole patient number. Of course, being capable of use and being easy to use are two different things. For certain anatomical sites, treatment with Unity has distinct advantages, while for others, there may be no significant difference from conventional accelerators. And Unity provide two processes according to the plan method, ATP and ATS. ATP is adapt precision, which used in condition that there is no much shape change and just need rigid registration to correct the translation error. And ATS was used in the condition that tumor shape changed, or ORS, organ at risk changed with run situation. I will explain this clearly on the slides after. We can observe that ATP accounts for a huge proportion, reaching 87.1%. However, I believe that ATS is one of the best demonstrate the advantages of adaptive radiotherapy. It's worth noticing that in the ATS cases in our center, prostate cancer accounts for the vast majority, approximately 80%. Okay, what is the character of Unity? It is a high-performance linear accelerator combined with combined with high field magnetic resonance. The part of accelerator is from Lecta, and the part of magnetic resonance is from Philips. It provides images with high soft tissue contrast with no additional radiation. On adaptive planning system, can lead an adaptive plan for tumor steady change. Real-time monitoring during the dose delivery allows doctors or RTTs to promote detect to mobility in the observation area during the treatment. In case any abnormalities, we can intervention immediately in the treatment, ensure the treatment accuracy and the safety. The MR system provide functional imaging, enable a more precise evaluation for tumor viability. Okay, let's move to the hardware. These are the components most frequently used in daily works. This is BMDM, beam monitor unity display module, which displayed and record the numbers of MUs in the most recent fraction. This is the safety guarantee, named last person out. We turn it when the last RTT leaves the treatment room and make sure there is no person except the patient left in the treatment room. It was not, if it was not turned, there would be an interlock on the accelerator with interlock to prevent the beam on. And this is FKP, the function keypad. It mainly have 3 buttons. The green one is beam on button. The yellow one is beam pause button, and the red one is terminate button. When you press the terminate button, you stop the radiation delivery and wall the movements, but not cutting down the electricity of the machine, which is different from the emergency button. And the fourth picture shows the index bar, which were used to fix the location of PPDs. That means patient positioning devices. This is the layout of the control room. It contains these consoles, and this is the real layout in our control room. Each center can lay out according to its own optional habit. However, the magnet emergency stop button should be covered properly in case of trigger accidentally. Okay, let's move to the next part, clinical workflow. As Dr. Tang just showed, at first, the upper part of it is the reference plan workflow. At first, patients should get CT simulation, and then doctor's control on CT image include tumor bed and OARs. If there is potential to use ATS, bones and air cavities must be controlled. This is very important, or it will decrease the dose accuracy of the adapt plan because MR image don't have the electronic density information. All the AD information are based on the ROI and ROI-ED assignment. Then physicists make the reference plan and individual dose check. After that, we pass the plan to the mosaic ready to use. The down part shows the workflow of daily treatment. Set up pre-MR acquisition and rejection, and according to the rejection result, ROs decide to use ATP or OTS. Then physicists make the adapt plan. After plan approval, the plan transferred to the accelerator across the mosaic. During dose delivery, real-time motion monitoring can help us to observe the organs movement through the whole treatment process. Okay, now I will demonstrate the entire process in detail. For the system operated normally, we should do the following items. This is our daily QA. In our center, these items are implemented by RTTs. And as I know, in some other center, some of them were carried out by physicists. And first, Unity contains MR system. So we have to test the stability of and accuracy of the MR system. We measured the helium level every day. And we check the helium system, such as the CO ability or other problems. Then we check the image quality through these 3 sequences. Among these, PIQT is composed with the transverse and the sagittal scoring. 3D geometric is used to check the image deformity. Then we should test the LINAC system, distinct from the traditional LINAC. This machine needs to train magnetron every day to avoid the interlock named arc. Then we test the output. After that, we have to do QA for the consistency named MR to MV. It's using MR system and the LIDAC MV system at the same time and compared in another platform to see whether the 2 systems stay in the same isocenter. At last, we use a phantom to execute the standard progress to verify whether there are communication issues in the entire treatment process. Okay, begin to operation the Unity. We should know the risk factors of the equipment. In addition to need to pay attention to the ionizing radiation, like conventional accelerator, Unity has a 1.5 T static magnetic field, which could produce a powerful magnetic force. So ferromagnetic devices and electronic products are forbidden to being carried into the treat room. So we are equipped with some tools like this, detecting items such as the hand scanner and the stand ferromagnetic detection system. This system is more sensitive and accuracy. And before our daily treatment, we should do daily assessment. The content include these items. It's not recommended to scan if the situation is not clear. During the scan, time verifying magnetic field would produce a large noise, more than 90 dB. So we should use earplug and or earphone for patient to decrease the noise, and it may cause the PNS. So RTTs should do scan-to-scan check, which can identify the conductive loops. We can use the supplied pads and hand grip to prevent the conductive loops. Another hazard is RF, that is radio frequency. Heating may be caused by RF. We have noticed that have to notice the patient situation and mind the value of SAR and SED. SAR less than 4 watt per kilogram and SED less than 7 kilojoule per kilogram are recommended. Another safety hazard is magnetic parts moving. We should mind the cables and the anterior coil. Do not move the tabletop unless you make sure the patient will not get caught in the equipment cable, which can cause the suffocation to the patient. And the cable may become hot and give burns to the patient. So what we should do when we treat the patients, first, for the safety of the patient, at least these items, these tips from our daily work. During the patient preparation, we do the inspection of ferromagnetic items and the daily assessment. When the patient set up, we should avoid the body loops and use earplug or earphone to reduce noise, using blanket for patient for warm keeping, and giving them nursing ball for emergency situation. When we operate the treatment coach, be careful about the cables in case of the scrap and the interning. And during the whole process, RTTs should observe the patient condition through the CCTV and pay attention to the SAR and SED continually. These are the pictures of headset, hand grip, and nursing ball. Make sure that headset hose is correctly rotated. Make sure that the patient can communicate with the operator throughout the process. Checking the nest ball and the headphones are functioning properly before use. The hand grip can help us prevent skin-to-skin contact areas through which the induced current loops can occur, which can cause burns. And make sure that PPDs are in correct position. If it's necessary, use the supported pads to prevent the skin-to-skin contact, and do visual checks that the patient is in correct position. And for ourselves, the safety for ourselves, we should remove all the free ferromagnetic items like hair clips, especially for girls, and coins, and some pens with the metal cover, and so on. We should put away the electronic products such as phones, watches, and electronic bracelets, etc. And the magnetic items cards should not carry into the treatment room because they may lose their function because of the high magnetic field. Then all the equipment related should be MR safe or at least MR conditional. You can see the marks MR in square stand for the MR safe, and in a triangle stand for the conditional. And this means it's dangerous, it's unsafe. Okay, let's move to the pre-MR image acquisition step. This table shows some MR sequences of our daily use in pre-defined exam cards. We can choose one sequence suited for the site for patient treatment. To our experience, tumors in brain, we often choose T2 or flare for the clear boundary. And for head and neck and thorax and abdomen, we prefer to choose T2. However, breast cancer most lymph node metastasis, we prefer choose T1 sequence. And pelvis tumor, most of them we choose T2 with 6 minutes. But when we do prostate cancer with ATS, we always choose T2 for with 2 minutes because for less slice to control and the efficiency, though we will lose some clarity. ATP is precision compensated suit for single, small, or rigid anatomies or target shape sufficiently that rotation are indeterminate. That means translational errors. Clinical candidates like breast, intracranial, bones, mets, and so on. However, if the tumor bed changed, especially tumor in the brain, they often shrinked or occurred the position caused by the change of the edematous area. ATS is recommended to use. ATS is shaped compensated. It's advanced, deformable, and DVH is if the target have rotational errors, deformational errors, or the volume changed, or the independent motion of organs, ATS is the best way to solve this problem. It's very likely to these sites like prostate, cervix, rectum, which is significantly affected by the filling degree of bladder or the rectum preparation. For multiple mets, their relative positions are prone to change, and other organs are easily affected by the such as respiration movement or other movement. And the biggest difference between ATP and ATS is whether it requires the online contouring or RIs by radiation oncologists and online adjustment of plan parameters by medical physicists. So ATS is more complex and time-consuming. This is the core reason why ROs do not prefer to use ATS on daily treatments. This video is ATS workflow download from the Electa. The first showed is the machine. In our Unity, patient positioning is performed firstly and set the body in coil and to use the automatic shape to enter the treatment bed position to the isocenter position. Then acquisition of image is performed before treatment. The video shows with T1 and then perform image regestion. This is the perform the regestion. After that, we check it and say if it were correct. This step maybe appears in the wrong position. In fact, this step for motion monitoring will be carried after the plan transferred to the accelerator. After the deformation regestion, we come to the next part, that is we choose ATS, the plan adaptation, and the RO will execute the ROI contours. And then physicists make the adaptation plan. After clinical review, if the plan meets our requirements, physicists will approve the plan and then transfer it to the dose delivery to the accelerator. During that period, the motion monitoring is carried. So it's about to be completed. We can also perform functional This is the stage where dose delivery. And this stage is motion monitoring. And after that, a functional image was taken. This is a DWI sequence to test the activity of this tumor. Okay, this is the whole process about ATS. And you may notice that there is no laser light positioning system that is different from the traditional LINAC. According to the product concept, no matter how the patient lies, the system can complete accuracy treatment by adjusting registration and planning. However, in order to raise the ratio of ATP, our RTT is still making some effort to improve the positioning accuracy. This article showed the method with ruler compared with just setting up by eyes. This is the left. There is a left and right laser light on the ceiling, which used to align the left and right. Then method A use eyes to set SI and AP direction, and compared with method B, use rulers by measuring the distance. The results showed there was a significant difference in SI direction. However, the times for setup had no significant direction, different. Okay, let's move to the registration. There are some experiences have been summarized by combining our clinical works. In most cases, we should do registration follow the tumor bed. That is the golden standard to every registration. Especially when we can see the tumor bed in MR images. It's much easier to achieve to be achieved than that in traditional LINAC. And if the tumor is on the bone or nearby the bony mark, we could use the bony marks as the registration target because their relative positions are relatively stable. And if the tumor bed is not easily to be found, and if the tumor area is not easily observed or the boundary is not very distinct, we need to select other markers as substitute for registration landmarks, such as the markers implanted, the vessel nearby, or others. In our experience, this situation is more likely to occur in the liver cancer. This is a registration video on breast. We can easily identify the glandular and the muscle tissue of the breast. And the registration results can be very close to the CT simulation, which also reflect the image advantages of magnetic resonance guided accelerator. Then we come to the challenge in ART now. This part is the continuation of the last part. However, I still divided into two sections because in this part, operation is not the key point, but the challenges. Back to the workflow of our daily treatment, I divided each step into different colors according to the role who executed it. MR safety check, patient setup, plan MR acquisition, registration, motion monitoring, and dose delivering are more often executed by RTTs. Controls in ATS, precision verification, and the plan result evaluation always executed by ROs. And adapt plan optimization plan approval, and individual dose check executed by physicists. These pictures showed the difference between the traditional LINAC and the mRNA. According to the relevant regulations in China, there shall be at least 2 radiation diagnosis or treatment staff members at the treatment room who needs to closely observe the patient's condition. But in mRNA, it become more completable. To ensure the quality of radiation therapy, there is at least 4 staff members in the control room, 2 RTTs, 1 RO, and 1 physicist. In traditional radiation therapy, treatment is likely an assembly line. RO is responsible for admitting the patients, formulating the prescriptions, controlling target areas, and then handing over it to the physicists. And then physicists develop a reference plan to verify them according to the doctor's requirement. And finally, the treatment is executed by RTTs according to the requirements, except for the first treatment and the special cases, doctors and the physicists may not need to be present at a treatment room. However, in mRNA, this situation becomes more complicable. In addition to the above mentioned works, RO also needs to conduct on-site evaluation of MRI, review registration results, and review the adaptive planning results, and check the position, and assess the MM mobility. Physicists also need to perform adaptive planning on the site. When ATS, physicists need to adjust the plan parameters online to meet the requirements of the prescription. Even in case of the treatment interruption, it's necessary for they to formulate a new interruption plan. Therefore, to sum up, the challenges faced by ART mainly lies in the following 3 aspects. First, the treatment progress is too long. Second, the workflow steps are complex. The third, the process is time-consuming and labor-intensive. So return to the daily treatment workflow. Today's education session, thanks to this platform, bring together the diversity range of sites and the experiences. For us all, the early implementation and adoption of Unity still requires the presence ROs and medical physicists and RTTs at the treatment console at the same time. However, we can recognize that this approach is not sustainable. Broad implementation of the mRNA will depend not only on the innovation workflow and development, but also on the re-evaluation of our traditional roles and the responsibility. So this part, I will talk about the role expansion for the MR-guided radiotherapy. At this event, where we are now, we are responsibility for the patient's arrangement, such as how to arrange treatment sequence for variety patients, different use, the ATP or ATS, or different preparation needed. We participated in patients' education and offer humanistic care. We do safety confirmation and must control the rhythm of treatment and control the timing for the notifying physicians and RO and the physicists to the treatment site, because they are too busy and have a lot of things to do. And we should play a role like a bridge links all parts of the workflow. And last, we should have ability to make the decision for online failures in case of emergency or unexpected situation occurs. So how do we expand our role of RTTs in on the MR LINAC? RTT roles in Unity online workflow tend to be reported as these 4 approaches. For ATP plan, there is no need to adjust plan parameters. So I think the RTT can completely perform the operation on behalf of the physicist. The first fraction plan result and reviewed by the physicist and the doctor. After that, under normal circumstance, the physicist could release from the treatment room. And for patient education, traditionally, this task is for doctors. However, in MR LINAC, due to the specific of the treatment, RTTs may be more familiar with the entire process. Therefore, RTTs need to help to provide more targeted education regarding the specificity of the process. Follow ATS workflow, RTTs could participate in some simple ROI controls, such as bladder, rectum, bone, and so on. If use ATS Lite, RTT, and physicists could participate deeper. Mention about this, I want to talk a little bit more. ATS Lite is a method of rapid plan adaptation with faster registration and faster optimization. The core is using ATS, but rigid registration. That is follow the A2S workflow, but propagate the structure rigidly. This is the key step about ATS Lite. Daily MR should PTV or OAR in shift or rotation position. ATS Lite is a simple rigid transformation to modify individual ROIs can improve the result of the ATP without recontouring during the online process. The key step is set the adapt setup to rigid for all the controls, not the deformable. So what's the benefits if we do this role expansion? At first, I think we could increase the efficiency of the workflow. Long time of the treatment not only affect the duration of treatment, but also affect the accuracy and the experience of patients. So more efficiently, the better experience the patient have. Then it can release radiation oncologists and the physicists from online workflows to carry out other responsibility, like clinicals, like MDD, and other research, which may help for the development for the whole site. And what's more important, that is directly improve the doctor's positivity and help for the patient arrangement. And even in this article, they talked about the cost saving for role expansion. So how to achieve this expansion? I think we should at least make effort from the following items. Number one is we need to get skills and the training required. Number two is we should do massive standard practice. And then number three, we should get deep discussion with ROs and physicists. Our aim is to improve efficiency without compromising medical quality. And in my opinion, the key points, the first always be safety, and then accuracy, and then efficiency. And this chart shows the distribution of treatment times for MR-Linac at our center over different time periods throughout these years. The first period is from December 2019 to September 2021. It contains the first case we tried to use MR-Linac. The second period is from December 2021 to September 2023. During this period, we have got some experiences and got some method to make the process more efficiency. And the third period is from November 2023 till now. During this period, we start to explore new approaches and implement to expansion our rules slightly. However, it's not enough. The result shows the improvement of our workflow efficiency. We got shorter time for the treatment. Okay, at last, I want to talk about the perspective of the MR-Linac. First, due to the advantages of MR-Linac, its application will definitely be more widespread in the future. And I suppose ATS, which is better to reflect the advantages of MR-Linac, will develop a larger ratio. Of course, the development of MR-Linac could not inseparable from the development of AI, just as Dr. Tang and Dr. Chen says. We should develop rapid, adapted, optimized method online, rapid scan sequences, and improving the computing ability. Which thanks to the effort to everyone present here. And the last not the least, the close cooperation of our varieties department is very important, not only for the MR-Linac, but also for all the new technologies. Thank you again to this platform. Thank you.
Yeah, thank you, Dr. Qin. Nice talk. You give us a full describe about the full workflow and talk about the new response for the RTTs. So does anybody have any questions? We're going to our Q&A session. So if we do not have any question, I just have a question for Dr. Chen. So you have mentioned that the AI driving the real-time tracking is maybe the future of the MR-Linac. So what do you think about the biggest limit is of the AI in this scenario?
As I mentioned in the my talk, the limitation, I think there are two major limitations. First one is the standardization of the AI, because as we all know, if we use the AI algorithm in one scenario, but if we want to move this new AI to algorithm to another clinical site, maybe not application, and the applicable is not quite very well as we use the first site. The second, I think we have to work together, because that we all know that the deep learning or machine learning all needs to big data set. And we need to global more information data set about this one to train their data and to help to develop an algorithm.
Wow, thank you. So I have another question about, so as we know that there is some other tracking device like the cyberknife that has the X-ray, use X-ray to track tumor. So what do you think about compared to the such device, the advantage of the MRI MR tracking is what's the advantage of
For the MR, the advantage of the MR guided radiotherapy, I think is, and the disadvantage about it is quite obvious because the MR acquisition time, as we all know, it's too long compared to X-ray. But for the satellite and the conventional linac, and the based on CBCT, the acquisition of the image of the online image is quite shorter compared to MR. And we should also notice that the advantage of the MR linac is there are superior soft tissue comparison to X-ray. So we can use the AI algorithm to help reduce the case spacing and sampling data so that to reduce the MR acquisition time.
Okay, thank you. So some audience ask a question about the AI-based QA for MR linac, both the machine-specific QA and the patient-specific QA. Do you have any experience about in this area or yeah?
Oh, yeah. That's a good question. Let me answer the first one. There is a routine QA for MR-linac, like daily, monthly, and yearly QA. Which one is already publication by the consortium, and the AI-based QA is under development. We try to use the AI tool to help reduce the frequency or decided how frequency we should do the QA for the conventional, also for the MR-linac facilities. And yes, there is the second one. There is a great impact on magnetic field, also on small field. The EI effect is on the phase boundary is quite visible, especially for the small field. And you can have a look at the recent public paper about breast cancer. And we should notice that for the EI effect, we have to make more bolus. You have to extend bolus. The field size of bolus should be larger than the conventional linac to make sure that the EI effect will not affect the skin dose for the breast cancer. And for the small field, we should be more careful about this.
Yeah, I also read that paper. I think it's a little bit complicated to explain. Oh, so does anybody have a question? So for the Dr. Ting, I still have a question about you talk about the response shift for the RTTs. So what do you think about RTT should learn and qualified for the in the MRI radiotherapy?
Oh, okay. I think we should learn about the some physics and some knowledges about doctors, and we must discuss with physicists and doctors deeply and get more training, such as this platform offered us the some lessons and trainings. That's very nice for us to get started.
So do you think you should start in school or just learning in the field or in the direct in the institution, or go back to the school, have some lessons about the
maybe it's
anatomical?
maybe it's late to go back to school. So we have to study on daily work. That is learn more about the trials and the physics, which we can use every day.
So thank you. So does anybody have any comments? Seems no comments. So thank you all for joining us this afternoon. We have had a hearing from 3 excellent speakers who have shared the variable perspectives on the AI driving motion tracking clinical experience with rectal cancer and technical advance in MR guided radiotherapy. So I think this session is inspired some new ideas. Thank you all. We were looking forward to see you in a future event. So
Yes.
I think we can close it. Yeah. Do you
Yeah,
have some
thank you, Dr.
thing to say?
Jiazhou. Yes. I
Yeah.
would like to thank you and the speakers on behalf of AFOMP. Thank you so much for moderating this webinar and leading the question and answer session. Thank you so much, Dr. Wang, for this nice time you moderated this, making the discussions also very active. And this is a new topic, and everybody is very keen on knowing further into the experience of people, those who have already have some clinical experience. So thank you to our speakers, Dr. Jiayun, Dr. Tang, Yuan, and Mr. Shirui for the wonderful talk. You shared your experiences. And thank you all the participants for your active participation, and looking forward to meeting you all in the next webinar. Thank you so much.
Okay, thank you, Mary.
See you. Thank you.
Bye.
Thank you. Bye.
Bye.